Thyroid surgery comprises the care of patients who either have known and confirmed or suspected thyroid problems, which may or may not benefit from surgery. So this generally includes patients who are known to have thyroid cancer, patients who have thyroid nodules, also known as goiter, which is swelling of the thyroid, and patients who have overactivity of their thyroid gland. And as a thyroid surgeon, my role is therefore to meet with these patients, to review and discuss their conditions with them, and to ascertain to what extent surgery is going to be beneficial to them. So typical thyroid surgeries would include either removal of all of the thyroid gland, we call that total thyroidectomy, or part of the gland, which we refer to as hemithyroidectomy or lobectomy. So thyroid surgery is required for patients who have thyroid cancers, which has been proven on biopsy. It's required for patients who have thyroid nodules. That means a growth within the thyroid. And these can require surgery either because they get to such a size that they may be causing pressure symptoms for the patient, and that may range from difficulty swallowing to a feeling of tightness, or because it's not possible to make an accurate diagnosis with a biopsy for those nodules. So, for example, around a quarter of patients with thyroid nodules who undergo a biopsy, what we call a fine needle aspiration biopsy, may end up with what we call an indeterminate result. And for those patients, the only way to get a full diagnosis is with thyroid surgery to remove that nodule and get a full answer with histological evaluation of the sample. So cancer and thyroid nodules are two reasons for surgery. Another can be patients who have known non-cancerous swelling of their thyroid with what we call a multinodular goiter, which has got to a size where, as I said, it's causing them symptoms such as pressure, compression of the voice box, compression of the swallowing, etc. Finally, patients who have overactivity of the thyroid, typically with something called Graves' disease, may require thyroid surgery if either they're not suitable for treatment with radioactive iodine or they've had a trial of treatment with radioactive iodine that doesn't work. So those are really the main groups of patients undergoing thyroid surgery. So the main potential risks and complications of thyroid surgery could be considered as the general complications of surgery and those of thyroid surgery specifically. So the first thing to consider for anyone undergoing this surgery is that it is performed under general anaesthetic. So the patient is completely asleep medically with a breathing tube in their throat. And on rare occasions, the anaesthetic in itself can be problematic in patients who have particular medical conditions or who are particularly frail. The next thing to consider is obviously the thyroid has to be removed through a scar in the neck. And although this is kept as small as possible, and I generally hide this within a natural crease in the neck and close it up with hidden sutures, there is nonetheless a scar in the neck. And whenever there's a scar on the body, there's the potential of risk for infection, although this is uncommon in thyroid surgery, it being a clean site surgery, and the potential for bruising and bleeding. Now, importantly in thyroid surgery, the gland is located immediately under the voice box, and the nerves to the voice box travel in close proximity to the thyroid. So there are four particular nerves of concern, two on each side. Those are the recurrent laryngeal nerves, which travel up from the chest behind the thyroid gland and insert into the voice box or larynx, and the superior laryngeal nerves, which travel from above down to insert into the larynx, into the voice box. And it's critical, obviously, that all of these nerves are preserved so that the patient has a normal vocal function subsequently. But a theoretical risk is that their voice or swallowing is altered if one of these nerves is bruised or injured, which can theoretically be either temporary or permanent. Now, the other thing to consider when we're removing all of the thyroid gland is that obviously a patient will require supplementary thyroxine, that's thyroid hormone supplementation. Now, if we're removing part of the thyroid gland, it's also possible that a patient may go on to require thyroxine if the remaining part of their thyroid gland isn't able to support their need for thyroxine. And that's determined on blood tests subsequently. And then finally, again, only if we're removing all of the thyroid gland, there is a potential need that a patient may have to take calcium supplementation in addition to their thyroxine. And that's because there are 4 very delicate glands called parathyroid glands located immediately next to the thyroid gland, which control the calcium balance in our body. And if those glands are bruised or injured and don't recover after thyroid surgery, a small number of patients may go on to need calcium balance supplementation as a lifelong therapy. So in relation to thyroid surgery, I like my patients to be aware that throughout their consultation with me, they should be able to understand what the condition is that they have, what the benefit would be of surgery to them, why it's recommended for them, and then what to expect in terms of recovery and subsequent prognosis. So following thyroid surgery with me, obviously there is variation because every one of us vary individually in our response to anaesthetic, to surgery, our pain thresholds, etc. So there is individual variation. But the standard scenario for my patients is that the vast majority only require a single night stay in hospital for monitoring, checking of blood tests, etc. And then they can be going home on the next day. It's normal to have a sore throat from the breathing tube of the anaesthetic, soreness in the front of the neck from the scar, and some soreness and stiffness in the neck muscles from the neck being placed under a little strain during the surgery. So all of these things are normal and they can be managed with standard painkillers, which means that the vast majority of patients, as I've said, are fortunately able to go home the day after surgery and continue their rest and recovery at home. Patients often ask if they're going to be able to speak after surgery, and the answer is yes, absolutely. The expectation is that from the moment the anaesthetic is terminated and the patient is awake, that they should be able to speak fairly normally, albeit with a sore throat from the breathing tube, and as I mentioned, a sore neck, obviously, from the scar itself. So they should be speaking normally, they should be able to eat normally, and there should be no restriction or any particular diet they have to follow. Although some patients after any general anaesthetic may find it more comfortable to be eating softer and cooler foods, that's not the case for anyone. And there's no particular restriction in terms of diet, as I've said. So standard painkillers, standard diet, and gentle return to full activities. The only real things that I make people aware of that they should avoid is anything that puts undue strain and stress on the neck. So that includes very vigorous exercise, heavy weight-bearing exercise, lifting heavy weights, etc. And all of that should be delayed just for 2 weeks until after surgery. I see all of my patients at that juncture so that we can review their recovery and plan what happens thereafter.